Okay, thank you. This is the second roundtable of the third pre-congress of OAFI, 2021. We are here in Barcelona, but we have connections to almost everywhere. So this table is about the pre- and clinical research with osteoarthritis patients after the COVID-19 era. And I have the pleasure to introduce to the speakers. First is Professor Ali Mobasheri, President of OARSI. Then will be Professor Leigh Callahan, Director of Osteoarthritis Action Alliance. And finally, Ms. Aina Pascual, Science and Research and Innovation at OAFI here in Barcelona. Professor Mobasheri, as I said, is president of the OARSI. It's also professor of musculoskeletal biology in different units. He has been born in Iran, in Persia, but has worked in many countries. He has been involved in teaching in different departments of orthopedics, of physics and technology in different countries. He is located in UK nowadays, but has experience, as I said, in medical centers in most European countries, Finland, Lithuania, the Netherlands, and so on. It's a very well-known expert on the field, and it's a pleasure to have him with us. Professor Mobasheri, when you like.
Thank you very much for the kind introduction. It's a pleasure to be here. Exactly 10 years ago, we were here for the OARSI meeting, maybe 9 years ago. And Josep and his colleagues were very generous, kind hosts for us. So it's lovely to be back in Barcelona. Hope we will return for many more collaborative opportunities. So as Xavier kindly mentioned, I work in several European countries, but I happen to have been stuck in the UK, remote controlling my teams from a small study in Lincolnshire. But I'm delighted to be able to travel again and see my colleagues face to face. Osteoarthritis is a big problem. As you heard from the speakers in the previous session, it is affecting 500 million people globally. And this is an underestimate, because we know that the true numbers are higher. We don't have accurate enough data for sub-Saharan Africa and South America. You heard all about the Lancet Commission. It's very exciting to be involved in this project, and I think this will have a really big societal impact, both in terms of public health and policy making. I'm not going to read this slide to you, but the key point about osteoarthritis is that it makes life difficult. You ask any patient who has osteoarthritis, no matter which joint is affected, their life is made more complicated by the disease. And the issue that it makes daily tasks difficult is a major ongoing concern for us. And of course, as I discussed over a very nice dinner with Josep a couple of nights ago, it affects your sleep, and it also affects mood. So sleeplessness and depression are increasingly linked to osteoarthritis. So OARSI presented osteoarthritis as a serious disease to the US Food and Drug Administration. This was in a white paper submitted in 2016, 5 years ago. So we know all about the risk factors, and obesity and age are key risk factors, but also the female gender. When it comes to obesity, obviously we're all getting older, so there is an age-related element to OA, but the really big modifiable risk factor is obesity and metabolic disease. So if that's something we can modify with beneficial health impacts, not just on the musculoskeletal system, but also on cardiometabolic health as well. So osteoarthritis is a serious disease. This lovely graphic was presented to us by our young investigators in OARSI who wanted to raise the importance of the seriousness of the disease. And I'm delighted to say we're going to run a competition for them to work on graphics to illustrate the importance of osteoarthritis for policymakers. So we know that there are no drugs, then there are no disease modifiers, and surgery is the ultimate endpoint, but it doesn't replace the original joint. Speak to any sports person who's had a knee replacement. Speak to any OA patient who's had a knee replacement. They'll say it just doesn't feel the same. Many people with OA cannot perform normal activities. 80% are limited with movement, and importantly, having OA increases the risk of cardiovascular, metabolic disease, diabetes, and hypertension. And of course, if you're not able to sleep, you can get depressed, and that becomes a vicious cycle. This is an inverse pyramid of treatment. Few need surgery. Very few people end up having to have a joint replacement. But we know that if obesity rise continues, more people will need replacement. And actually, in the last 2 years, many of the healthcare systems are behind in terms of performing joint replacement surgeries. So there are millions of people on waiting lists. Some people will benefit from drugs and intra-articular injections, but everybody should be educated to exercise and maintain a healthy lifestyle. And I think somewhere in there, there will also be opportunities for supplementation. And many patients with OA take supplements, even though the treatment guidelines may not recommend it. I'll come back to that. So I was delighted that David was joining us earlier today, and I've borrowed one of his slides. I hope that's okay, David, if you're still online. So what can we do for the OA patient? We are able to treat obesity, sedentary behavior, mitigate the impacts of joint injury, but we need to reduce load by managing weight and develop new therapeutic interventions. And of course, we have a lot of work to do in that area, but we hope to be able to do that with the patients. The treatment guidelines by the major organizations have all been published in the last 2 years. SKO guidelines in 2019, and this was followed by OARSI guidelines and also the ACR guidelines. These are very similar. Of course, there are subtle differences between them, but overall, there's a lot of similarity between them. Even the OARSI treatment guidelines that were published exactly 2 years ago, August 2019. Some of the key points are highlighted here. Mind-body exercises are being promoted. Topical NSAIDs are strongly recommended for knee osteoarthritis. Some of the oral non-steroidal anti-inflammatories not recommended in some comorbidity classes with cardiovascular disease, people with cardiovascular disease. Acetaminophen, paracetamol was not recommended. I mean, I can tell you as an OA patient myself with osteoarthritis in my left knee, paracetamol just doesn't work for me. It might work for a headache, but it doesn't work for my joint pain. And I think it's an important message that we need to give to the patients. In some people, it just doesn't work. And that's a personal, I just want to make sure everybody knows, that's a personal opinion. Opioids were not recommended. There is an opioid epidemic in the United States, in North America in particular, and duloxetine was not recommended except for those patients with concomitant depression. Some really interesting and important good clinical practice statements came out of the work, including weight management, mitigating the risk of giving NSAIDs, and of course, intra-articular injections. What do you give? The benefits short-term versus long-term, and is intra-articular corticosteroid really safe? What about long-term repeated use of intra-articular hyaluronic acid? And of course, many of the other societies are actively discussing and debating these issues. I was in Krakow in Poland just a few days ago at the Intra-Articular Injection Society, and of course their business is developing the next generation intra-articular injections. And of course, pain management programs that you can implement in conjunction between a healthcare provider and a patient. We recently published a comparison of the OARSI and SKO treatment guidelines, and the key difference is highlighted here. Low-dose, short-term acetaminophen, pharmaceutical-grade glucosamine and chondroitin sulfate are recommended by SKO, whereas OARSI doesn't recommend them. Which also includes, OARSI doesn't recommend glucosamine and chondroitin formulations. But let's face it, in Europe, these are considered to be pharmaceutical grade. They're quite pure. So it is important to consider the continental differences between the guidelines and how different regions and territories view drugs and supplements. I was specifically asked to say a few words about tackling OA during the pandemic. My good colleagues, Francisco Rocha and Francis Berenbaum, have written a paper on this topic with highlighting research agendas, and I'm not going to read this slide to you. I will simply say that the paper concludes a worsening of symptoms and progression in OA patients is expected after this period of confinement, especially in those inner cities where movement has been less possible. Now, of course, if you live in an open area, you can go and walk and exercise. Compared to an urban environment, there's going to be different outcomes. But we need to think about how we address the post-COVID problem of OA and pain, because the depressive state during the pandemic has also impacted on pain perception. And of course, we know diet and exercise combined are the best treatments for osteoarthritis. And the work that's been done by Steve Messier and his colleagues in the IDEA trial have demonstrated the beneficial effects, the synergistic effects of diet and exercise. And of course, as Erasmus said, prevention is better than cure. And as you saw in David Hunter's presentation, even in the draft figure for the Lancet OA Commission, at the very beginning of life, you need to put measures in place to keep active and prevent the metabolic and cardiovascular diseases that could exacerbate OA. And of course, we know that when you lose weight in individuals who undergo very significant weight loss and are exercising, pain drops off, and some of the inflammatory markers are also significantly reduced. So we already have a treatment for osteoarthritis for the public health setting. So let's use it. Let's make sure that message gets out there. And benefits, there are many other benefits of exercise on health, whole body level, muscle, adipose tissue health, and also vascular health, cardiovascular health. And we know that it's, I think this year has been the 100th year of insulin. Insulin was developed 100 years ago, so we've made significant impacts on diabetes. But of course, there's a lot more to do, and there's, I think, fantastic opportunities for repositioning some metabolic drugs from metabolic area to osteoarthritis. What can we expect in the years to come? So I want to give patients some hope. Even though the drug pipeline has been particularly difficult, leaky, lots of things have fallen out of this. It's a complicated, expensive business. But we need to consider the fact that comorbidities and the patient profiles influence outcomes. So actually, osteoarthritis is no longer one single disease. It's a series of different phenotypes, and outcomes will depend on the patient profile. You can develop drugs that target different compartments, cartilage, subchondral bone. You can develop new agents to target inflammation or pain. And you can inject these or give them orally. But I think future drugs will probably focus more on injections directly into the joint or even into the spine. But one of the big problems is that when you inject a drug into the joint, the synovial circulation takes it away and clears it. So we need to develop drugs that have a longer half-life in the joint and longer impact. And I think this is where cell and gene therapy could really have an impact, because they overcome this issue of half-life to a certain extent. Again, I'm grateful to David for this. He gave a wonderful presentation some months ago highlighting some of the drugs that have been in clinical trials. Even in the last few months, a couple of things listed on this slide have fallen out and failed at phase 2. But there's still lots of things being pushed through. We published a paper about the window of opportunity for intervention in early osteoarthritis in early life, and this is, I think, where we can have a big impact on society. And obviously, not everybody will end up with joint death and joint replacement. If we can identify some of the key factors, some of the genetic factors and some of the biomarkers that predispose to OA, we can have a bigger impact on society from a healthcare and insurance perspective. And after all, we are in an AXA auditorium. I believe AXA is an insurance company. So I think insurance companies are also very interested in outcomes for osteoarthritis. Let me say a few words about the microbiome. They're not just in your gut. Apparently, they're everywhere in the body. It turns out that obesity influences the microbiome, and the microbiome can make the joint conditions worse. And it turns out that the microbiome is a substantial mass in bodies, like 0.5 kilogram. And it can be good and bad. The good microbiome can promote health. An unhealthy microbiome can promote disease. So maybe we could identify the bugs and the genes and identify the transcripts, what they make using all the modern tools of research, and be able to influence that microbiome to promote joint health, muscle health, bone health. We know that the gut microbiome is the so-called new frontier in musculoskeletal research, and we also know some of the cohort studies have indicated that intestinal microbiome can have an impact on pain and inflammation. In fact, the amount of streptococcus in the gut can influence how much pain you sense. So, I think this is a very promising area, and I think we should pay attention to it. And of course, we need to consider that the microbiome is influenced by exercise and is influenced by what we eat. But what we eat has also significantly changed over the last couple of 100 years. The Industrial Revolution has had a major impact on how we move and what we eat. And I think there's less fiber, there's less protein, there's more refined carbohydrates, more refined sugar, and there's less vegetables in our diet. Of course, these are going to influence the microbiome. And potentially, there's the opportunity to supplement the microbiome with joint health supplements, that can promote beneficial gut bacteria. Now, most of this research comes from preclinical models, from rats and mice, but I think we're moving towards doing these studies in humans. And patients, osteoarthritis patients, are going to be absolutely critical for the field to move forward. So the microbiome can impact joint health, and exercise can modify the microbiome together with diet. So we need to consider these. What about new therapies? Well, we know that intra-articular or subdermal interleukin-1 beta has produced mixed results in terms of antagonizing its actions. Some of the trials have failed, but this trial by Novartis has actually a very large number of patients, and the patients had myocardial infarction. And it turns out that in 5,000 people who received the treatment, there was up to a 40% to 47% reduction in total knee replacement. I think that's an important outcome. So it highlights the fact that actually interleukin-1 beta does play a role in the disease, and also we could modify it with benefits not just for the joints, but also for the cardiovascular system. There's also various gene therapies, cell therapies. I should have mentioned in my beginning of my talk, in my disclosures, I was going to mention 2 products from Colon Tissue Gene and also from Flexion Therapeutics. This is a mixture of chondrocytes and programmed GP2293 cells overexpressing TGF-beta1 with the hope of reprogramming inflammation within the joint. This is in phase 3 clinical trials. It's potentially possible to take the same approach and inject the intervertebral disc to try and reverse the changes that you see with intervertebral disc degeneration. The Flexion pipeline is an interesting pipeline. I heard yesterday that the company's been bought out by Pacira Pharmaceuticals. That was in a press release published yesterday. They have Zilretta, which is an extended release injectable suspension. This has been FDA approved. And there are 2 other products, a gene therapy and a sodium channel inhibitor for acute post-operative chronic joint pain. And these are in phase 1 and 2. And the idea of gene therapy also is incorporated into this FX201 and is built on interleukin-1 receptor antagonism through sustained delivery of adenovirus vectors to the joint. I mentioned viruses. We live in the post-COVID world. What did we learn from the COVID-19 vaccines? In this room, people have had, I'm sure, Pfizer, AstraZeneca, and Moderna. What can we learn from these vaccines? Well, we've had mRNA vaccines and vaccines based on really well-established technology, adenovirus vectors. And there's also the Russian vaccine, Sputnik 5. We can potentially take these technologies and reprogram the joint using intra-articular injections. This is not science fiction. This is science fact. It's going to happen. And I think it's a wonderful opportunity for us to give hope to the OA patients that some very sophisticated science could be put in the next generation drugs. So in terms of future prospects, OA is a challenging disease. Lots of drugs have recently fallen out of the pipeline. No approved D modes exist. There are very few biomarkers. And several phase 2 clinical trials have also failed. And most recently, just I think last week, the EMA, even the EMA rejected tanezumab for joint pain. The FDA rejected it back in March, I believe. But I think there's a lot of therapeutic pipeline activity, lots of promising drugs, and there's lots of hope for OA patients. So I want to finish this presentation by giving hope. We work hard. We continue to work hard with colleagues at OAFI, and this interdisciplinary collaboration between us is really important. And we hope to incorporate patient views in everything that we do in the future, right down to hypothesis development. Thank you very much, and it was a real opportunity to spend time with you. Thank you.
Thank you, Professor Mobasheri, for the overall perspective and general overview of the current situation in the field. Now we move to Professor Leigh Callahan. She's director of the Osteoarthritis Action Alliance. There's a coalition of more than 140 organizations committed to elevating the osteoarthritis as a national health priority. He has been working in Chapel Hill, North Carolina, the Triangle Park. Hello, welcome. Good morning, Leigh. Are you there?
Hello, I'm delighted to talk to you about the Osteoarthritis Action Alliance during this pre-Congress session. The Osteoarthritis Action Alliance is a coalition of more than 140 organizations committed to elevating OA as a national health priority and promoting effective policy, both systems and environmental solutions that address the individual and national toll of OA. We focus on increasing the awareness about the prevalence and seriousness of OA, expanding education for healthcare providers, people who have OA, policymakers, and community organization leaders, and focusing on solutions for both the prevention and management of OA through delivery of tools, resources, and evidence-based programs. Our website is listed below. During the past year, individuals across the globe have experienced barriers and issues related to the COVID-19 pandemic. There have been common barriers that we have all had to deal with. And then there's been the reality that for patients with osteoarthritis, some of the common barriers are listed on the left side, and then the reality for the OA patients on the right. So you can see in terms of employment, unemployment, and reduced finances, patients with OA have had greater hardship with buying pain medications and covering their medical care. They have had reduced access to parks or other outdoor spaces for physical activity. And physical activity is one of the main management strategies that can be used for managing pain and other symptoms and problems with OA. Limited access to medical care has translated for OA patients into delayed joint replacement surgery, delayed joint injections, or delayed access to physical therapy. Limited ability to meet basic needs translates for people with OA into more difficulty acquiring groceries and pain medications and performing household chores. There's also been a loss or reduced services of formal and informal caregiving services, and lack of reliable internet connection has resulted in reduced access to virtual medical care. And that has been an important way that people have gotten many of their medical visits during this pandemic. Also, lack of access to the virtual lifestyle management programs, and many of the arthritis appropriate evidence-based programs and interventions have been translated into a virtual format. The closing of gyms and other fitness facilities leads to reduced access, again, to physical activity, and also reduced social support. increases in stress, depression, anxiety, and social isolation just exacerbates the difficulties that were already there for people with OA who are already at greater risk for depression and at greater risk for social isolation. And the worse outcomes for people of color has an impact in people with OA because OA disproportionately affects minorities. At the Action Alliance, we have a number of resources that are targeted for people with OA and targeted to be accessed remotely. One of our resources is a portal for the Self-Directed Walk with Ease, which is the Arthritis Foundation's evidence-based physical activity intervention that has proven to reduce pain and stiffness for people with OA, increase balance, strength, and walking speed, and also increase the ability to confidently manage arthritis symptoms, increasing individuals' self-efficacy. This program is a 6-week program. It's self-paced. Individuals go through the guidebook, which you can see on the right of the slide, the Walk with Ease guidebook. And the guidebook leads the participants through the program with chapters that include information on tips on goal setting and overcoming barriers when people get stuck in their walking program, information about stretching and strengthening exercises with specific pictures and step-by-step guidance to do these exercises, and other tools and resources such as walking logs and assessments where people can assess their current levels of pain at baseline and assess it along the way to see whether they are improving with their walking. This program can be done alone or with others, and it can be done inside or outside. And having programs that could be done outside was particularly useful during the pandemic. The website for this is listed below, www.walkwitharthritis.org. We also developed a number of resources targeted specifically around COVID-19 during the pandemic, and we created a web page which compiled many of the physical activity, weight management, pain management, and mental health resources. We put together this web page or the resources on the web page as when we curated them with OARSI and the Joint Action Partnership, so that we would try to have the most robust set of resources available for all individuals. We also posted a guide for exercise during COVID-19 and tips for staying active when people need to stay at home. Recently, we launched a new patient resource portal, and on this portal, we have videos available for patients, educational resources, and tips about what is OA, how do you manage OA, how do you prevent it, how do you stay active with OA, weight loss tips for people with OA, and just overall information about getting connected. The Action Alliance supports 2 online support groups for people with OA. One of them is Health Unlocked, which is the world's largest social network for health. There are more than 1 million members in Health Unlocked all across the globe. And if someone wants to join this, they can join through the Osteoarthritis Action Community and connect with other individuals with osteoarthritis. We also support the Stand Up to OA Facebook group, which was created as a safe place on Facebook where approved members can share their goals, questions, and everyday struggles with OA. And there are more than 4,000 members on the Stand Up to OA Facebook group currently. Coming soon, toward the end of 2021, we are going to be launching our new OA Care Tools resources for healthcare providers, patients, and employers. And they will have information about getting started with physical activity for arthritis, finding your way through joint pain, and osteoarthritis in the workplace. We are also in the midst of developing a number of resources for Spanish speakers. The Walk with Ease program has a Spanish version, Camino con Gusto, and we are developing a portal similar to the portal I described to you for the English-speaking group. And as the English-speaking group has, same as the English-speaking group has, the portal will provide people with ways to track, and also send people motivational emails to keep them on track going through the guidebook. And we are also updating our a webpage and our resources to have culturally appropriate webpage that's dedicated to OA resources and tools in Spanish, including a link to Camino con Gusto. So I thank you all very much for your attention, and I hope you enjoy the Congress.
Thank you, Leigh. We have listening to you with gusto. And now we are moving to the next speaker, and as before, we will have the questions and answers. Now it's turn for Aina Pascual. She's Science and Research and Innovation at OAFI. She's in charge of the organization of the research activities in OAFI. Thank you, Aina, and the floor is yours.
Thank you. Well, I'm just going to explain you a bit how we are working in OAFI to improve the disease management throughout innovation. Well, OAFI is an independent non-profit foundation to promote the scientific research in the field of osteoarthritis. We create a bridge between patients, researchers, medical societies, and companies. We want to improve OA patients' quality of life. For that reason, we put the patients in the center of our research. This way, we assure patients' needs and priorities in the research, and we allow patients to manage their disease. We have 4 research lines. First of all, we have international projects like the Task Force. We have European projects like Preventomics and Triangles. We also have our own research with projects like AVIPA and the OTPAR. And finally, we also participate in clinical trials like ARSI and Gaudi. Now we are moving to the international projects. The OAFI and the Arthritis Foundation leads the implementations of the OA Patient Task Force. This is an alliance between the most important associations of patients with rheumatologic problems in order to work together globally with a focus in the osteoarthritis. With all these associations, the OA Patient Task Force represents more than 150 million patients worldwide. Now I won't explain more of the task force because today we have a session more focused on that. Moving to the European project, first of all, we have the Preventomics. In Preventomics, personalized nutrition tools aim at improving health and preventing the onset of diseases. Preventomics personalized nutrition and lifestyle habits plans to improve people's health based on the individual characteristics and will reach recipients in the form of behavioral guidelines, thanks to the use of information and communication technology tools. The project opens the door to the personalization of treatments for the prevention of chronic disease throughout nutrition. Here, there are many partners participating from several Europe countries like Spain, Italy, UK, Netherlands, Greece, Denmark, and Poland. The other project is the Triangle. Tendinopathies and osteoarthritis are extremely common, and these injuries are associated with a high health and financial cost. There is no treatment that restores the full strength and functionality of the tendons. Triangle aims to develop bioprinted 3D scaffold based on collagen and gelatin, functionalized with stem cells and nanoencapsulated regenerative factors. Surgical implantation of these new biomaterials will allow the targeted administration of biological active agents to allow better and faster regeneration of injured collagen-rich tissues, such as articular cartilage, ligament, and ankle tendon. This will allow to increase the recovery rates of the ankle joint functionality by 10 to 15%, and it will reduce the recovery time and associated healthcare costs by up to 50%. Here, there are 12 European partners, companies producing biomaterials, manufacturers, technology experts, material engineers, clinical validation centers, healthcare professionals, patient associations, and other experts in ethics, regulation, and exploitation. In our own research, we have the two main projects. They are CAVIPA and OTPAR. CAVIPA is the survey on the perception of quality of life in Spain with osteoarthritis. It analyzes the perception of patients' quality of life with knee and/or hip osteoarthritis and their associated factors. This is the first survey in Spain that evaluates the quality of life as an indicator to include in the OA treatment programs. On the other hand, we have the OTPAR project, which is the care pathway of patients with osteoporosis. This is an assessment on the medical assistant experience, needs, and quality of life of patients with osteoporosis. It was launched by OAFI and ECOSAR. In the CAVIPA project, they were participating 208 patients. The results show the profound impact of OA in life of people. Patients need more information, empathy, understanding, and treatment. As the main conclusions, we can say that the mean of delay in diagnosis was of 3 years, and the more delay, the worse perception of health and satisfaction with treatments had the patients, and also more cause of the disease. 94% of patients suffer from comorbidities, and depression and anxiety were the most common ones. Also, these comorbidities worsen the health and quality of life of patients. From 30% to 40% of the patients implemented hygienic and dietetic measures. However, 79% of them didn't improve their OA. We thought that probably is due to the lack of time of the health system to support these measures. 60% suffer from limitations and 33% ask for sick leaves. We also see that the more limitations had the patients, the worse health, quality of life, and satisfaction with treatments they had. Also, pain is the first word that patients relate with OA. And finally, most patients perceive their health and quality of life as regular. These are the main conclusions. However, I invite you to assist to our Congress, where will be a session with more details with this study. The OTPAR study is a related study, but with osteoporosis patients. They included 12 patients distributed in 2 focus groups and some individual interviews. We saw in this study that patients and associations are an opportunity to find additional support and comprehension that the medical health community can cover. As main conclusions, we can say that patients comply with the treatment and advices, that patients also need more information, communication, and attention. Patients who were hospitalized for surgery describe satisfactorily their experience. COVID pandemic has generated 2 beliefs. On the one hand, we have patients who felt unattended, and on the other hand, we have patients that felt that there wasn't any stop because the habitual monitoring is annual. And finally, the osteoporosis has negatively affected the quality of life and mood of patients. The clinical trials we are participating on are the GAUDI and TARSIDOS. GAUDI is a randomized, double-blind, placebo-controlled study to evaluate the efficacy of pro-resolved sports in the treatment of symptomatic knee osteoarthritis. This is a clinical trial to validate the efficacy of a food supplement, which are the results. They are natural molecules that reduce the inflammatory response, and they could be taken for long periods of time for patients with knee OA. On the other hand, we have the ARSIDOS project, which is a randomized, multicentric, and double-blind clinical trial to evaluate the efficacy and security of new drug in patients with erosive osteoarthritis of fingers. Finally, I would like to present all our team in OAFI that make possible all this research and other works that we have. And from all of us, thank you all.
Thank you, Aina. Thank you, Leigh, and thank you, Ali. Now we more or less are on schedule, so we have 10 minutes at least of questions and answers, including those who in the previous roundtable raised their hands and couldn't participate because the controller didn't allow them to do. Fernando, would you like, the previous question? Thank you.
No, my point is regarding another presentation, okay, but my point is that in the last year, that's clear that the open access to medical journals changed dramatically the field. So now lawyers, journalists, lay members, everyone read in internet the medical journals. This is absolutely new in our life. It is, even for me, it's very easy to read more journals, but in other light of my life, because I don't need to pay to read the journal. So we live in a new era in which everyone can read the journals, even they are peer-reviewed or not. So this creates, in one hand, confusion, but on the other hand, create a new ambient in which there are necessity to explain clearly the results of the trials of the medical journals. So for me, this is absolutely new. It is a dramatic change in the scope of this kind of issues that we are discussing. Thank you.
Yeah, if you permit, I fully agree. This is a new paradigm of situation, brand new, that is an obligation for us to think about what is coming here. Because I think what we need is to improve the quality of the understanding of the methodology of research and of science. Because, as you said, the spread of knowledge has been enormous. Now everybody's using journalists or any personal who has access to the social media, and everybody has. So we need to make a great effort of education of what is the game, what are the rules of the game of science, because public is not very much aware, in my opinion, of the rules of the game. That's that's brand new. That's brand new, and we must confront this and try to improve the knowledge of the lay members, journalists, and people about this.
I completely agree. We have an obligation to increase our interactions with patients and politicians and policymakers even more now, because the pre-publication platforms are now so accessible by journalists. And there have been so many reports of over-sensationalization of research done in a very small trial, over-interpretation of that data. Now, look, there is an important political dimension here. We're in Spain, a democratic country where the government cares about people. If I may just comment on my own background, I come from a certain part of the Middle East where the government doesn't care about the people. So if a paper is published that says one particular drug that might be used as an anti-parasitic drug is superior to a vaccine, that will give that government an opportunity not to vaccinate its citizens, to save money, and to give people a treatment that doesn't work. That is in a non-democratic context. Believe me, it exists. It's out there. There are many countries where democracy already doesn't exist. It's been undermined. And I think that's one of the dangers that we don't really think about much, because we live in Europe, in a union, and in a context where our governments care about us, but that does not apply to the rest of the world.
Also, I found very interesting that in Aina's presentation, you divide your work in 3 areas: own research, European projects, and international projects. You mean we are Europeans, all of us? Because otherwise, what is it?
Yeah, you are right.
More questions? Yes, please.
Good morning to everybody. I'm Dr. Leigh Montey from Science Liaison in Reggio Fre company. And thank you very much, Professor Mobasheri, for your really kind and very nice, complete overview about the current state of OA. And I would like to ask you if, because I don't understand if there has been a recognition of OA as a serious disease already, because I remember when I was in Bioverica, the submission of the white paper, and I don't know exactly what's the status of this recognition by FDA and other organizations or health authorities.
Thank you for your very kind comments. Yes, there has been a formal acknowledgement by the FDA that osteoarthritis is a serious disease. So it's taken a long time, but I was very pleased to see the FDA published a paper in December 2020 proposing new concept endpoints for future osteoarthritis clinical trials. That, to me, is an indication of the acknowledgement of OA as a serious disease white paper and further engagement with the community that allows us to talk. We actually had a joint workshop facilitated by the Arthritis Foundation. FDA were invited, and that was in June, and there's going to be a follow-up to that. There's going to be a proceedings published from that. And I'm also pleased to say that the OARSI Clinical Trial Symposium, to be held later this month, will also involve FDA speakers. And we'd like to have that engagement with the EMA as well. We recognize we've not had that engagement with the EMA. We need to have that engagement, and I'm sure with the help of our colleagues at OAFI, we can start working together. So maybe we should invite EMA colleagues to our future conferences and highlight the research and the clinical development that we do. But I think we have a lot more work yet that remains to be done.
Thank you so much. And sorry, I would like to know your opinion about all these new technologies for COVID-19 vaccines, such as mRNA and adenovirus, injection. What's your opinion in OA? Because we were thinking about it's better like a method to improve the delivery of intraarticular injections and to avoid the removal from synovial fluid, or maybe it's better like the other product in order to carry some proteins that maybe it has able to exert some anti-inflammatory activity. What's in order to add a protein or to in OA, because
sure. So we need to think about how long that product, if it's a protein or a recombinant protein, how long is it going to last? There's going to be need for repeat injections, just like with hyaluronic acid and corticosteroid injections. You need to have repeat injections. There's no question of that. But the ability to genetically modify, or at least inject a product that can have a much longer lasting impact on the joint, that is what's being promised by this new, well, it's not really new, the COVID vaccines. The technology was rapidly implemented. It was pre-existing, but the pandemic forced rapid implementation. So it's already out there. We just need to be very clever about how we implement it. To do that effectively, we need to understand the phenotypes, and the intra-articular phenotypes we need to get a really good handle on. In the meantime, patients can continue benefiting from those key words of advice about weight loss, physical activity, mind-body exercises, all the really good messages in the treatment guidelines. But in the long term, I think we have a great opportunity to begin to test some of these technologies for the next generation intra-articular injections. If I was an investor from a venture capital company, I would be seriously looking at opportunities for the next generations, because the tools are already in place. But we just need to determine what are the molecules that need to be modulated and how do we alter that intra-articular environment. That is for cases where the phenotypes are intra-articular. But of course, for the majority of OA patients, we're talking about lifestyle modification and more holistic approaches to treatment. And I think that's an important point for all patients to consider. In the majority of cases, it is public health. It's a public health matter.
Thank you.
Perhaps, Ali, there's some investor here that is interested in this field.
Well, I must say I don't have any scientific interest in those products myself, but I know that they are in the process of being developed. I've not invested, I don't have any conflicts to declare. But I think if you want to return from your investment, you look to the technologies that are existing rather than things that could be developed in the next 3, 7, 10 years.
We take note of that. So, some other question? Yes?
Only a short remark about the new environment we are living regarding lay press and patient pressure. I used to work in HIV field since the beginning, and the involvement of people living with HIV was a key factor for the success. My friend Tony Fauci invited them to speak. At that time, I worked with Wellcome and after with Glaxo. So we organized a community advisory board. Patients help us to change the design of clinical trials. For instance, the ethical issue regarding the experimentation of ritonavir. We were able to include surrogate markers. FDA changed the procedure in order to have expanded access. In France, there is A2. This is another tool. So I think it's quite new, this environment, probably for the dimension, but not for the concept. There was a wonderful book written by Epstein, that is a sociologist. He told that activists, people living with HIV, were outside the university, claiming that when you're studying, we are dying. So the distance between the time of the virus and the time of the bed were reduced because the lay people were active in this field. Larry Altman published on the New York Times the first article before any article published in scientific press. The Concorde trial were announced in Berlin in 1993, and it was fully published in The Lancet 1 year later. But the impact of the presentation were greatest. The standard of care changed, and in the panel of a guideline, people living with HIV are still involved because the user side is a perspective that is very important to overlap the daily problems. For instance, lipodystrophy, that was a very hard to manage side effect of some drugs, were managed before by people, changing the dosage. And we, at that time, I was in Glaxo, we have to reconsider the use of our drugs thanks to help or the pressure or the aggression. It depends by the point of view. So it's quite interesting. The distance of time between a clarification of an issue in the scientific community and the time of production of public opinion about the same issue with HIV started to reduce, and now there is no space. Mm-hmm. So this is the reason why we have to learn how to communicate. Mm-hmm. And speaking is a resource, it's not a danger.
Yes, of course. It's all about storytelling. And I think if two patients are involved at the beginning of a scientific meeting, a one-day focus meeting, for example, I went to recently on hand osteoarthritis, was facilitated by SKO, the European Society for the Economic Aspects of Osteoporosis and Osteoarthritis. The first hour was given to the patients. Tell us your story. What is your life like with hand osteoarthritis? And the patients came and told their story from their early, 30s to the present time, and all the challenges that they experienced in their work life, in their daily life, in their marriages, in their relationships with others. And I think it was really very illuminating for a group of scientists and clinicians to hear those stories. After all, long before language,
evolved and writing was evolved, human beings were telling stories, and the stories were passed down the generations. And I think we need to bring that element of humanity back. Ask the patients to tell us their stories so that we can engage with them and develop the best treatments and interventions possible.
Thank you all for this last important message. I think that it's time for a break now, so that will be the end of the second roundtable on the third OAFI Patients Pre-Congress.